Well, I also want to greet all the present people, particularly welcome to all the guests and the scientists who accepted our invitation to participate in this meeting. And I'm doing that also on behalf of Cerletti, Bernardinelli, and Borletti, who are part with me of the scientific committee of this group, which we actually accepted to work with enthusiasm, also think to the strength shown by our beloved Beatrice. With much pleasure, together with Professor Nigro, my co-chairman, I now have the pleasure and the honor to start this conference. And I strongly believe that this might bring to an improvement in the synergies and the possible collaborations that might bring to an improvement in our knowledge as regards diseases like sarcoglycanopathy, particularly to say what's written in the title of this conference, What's Next? What will be the possible future for the technological and scientific development that might bring to the improvement first and possibly, definitely, to the treatment of these diseases thereafter? With this, I think we now have to pass on to science and shortly introduce the speakers of the morning. First speaker, whom I have the honor and the pleasure to introduce, is Professor Jerry Mendell. Professor Jerry Mendell is a neurologist at Nationwide Children's Hospital in Columbus, Ohio, professor of pediatrics, neurology, pathology, and physiology, so my colleague in this case, at Ohio State University College of Medicine, director and co-director of several research centers for gene therapy. He was among the first to test these new technological approaches for muscle cell transplantation, particularly aimed at Duchenne muscular dystrophy from the early 1990s, and he was the first to study the possibility of gene transfer in these dystrophies through viral mediation. He was awarded several awards, particularly by the Muscular Dystrophy Association at The Ohio State University, and he was named among the best doctors in America. So, Professor Mendell, please join us here onto the floor and give us your presentation. Thank you very much.
Well, let me start by saying that I can't speak Italian, so you'll have to tolerate that. But it is a great pleasure to be here at the first international meeting of the Beta-Sarcoglycan Society. And I realize I only have a few minutes to talk, so that doesn't give me much time. But I would like to tell you by introduction really what we really do and how this has led to our what we think will be a successful treatment for beta-sarcoglycan disease in LGMD2E. I want to, in this talk, introduce AAV gene therapy. I assume we have some naive people in the crowd who don't know much about that. Talk a little bit about our success in alpha-sarcoglycan and where we're going with that, and then, of course, address any questions. What I want to emphasize in this talk at the beginning rather than at the end is that to be successful in gene therapy, you must have a team approach. And that basically is our goal. We have a very large team at Nationwide Children's Hospital, and we have, obviously, Louise is here with me, and we've worked together now for several years. She's one of our research scientists in the Research Institute at Nationwide Children's. We make our own vector production by one of the pioneers of AAV gene therapy. Other interested, important people in our center are Zarif Shahank. We work with a radiologist and ultrasonographer. I'll show you his role. Someone who's helped us develop vascular delivery. And then when we take this to trial, we actually have a perfusionist who stays by our side. So you can't be successful, and this represents only some of the key people out of maybe 75 people in our center. But let me just start with what is adeno-associated virus. This is the friend of ours that we use and why it's so important. It's important because it doesn't cause any human disease, doesn't have much toxicity, and it expresses from an episomal location. And what that means is that it doesn't integrate into the genome. So by staying in this very safe place, it can express for long periods of time without bothering any of your other genes. That's extremely important, and we've learned that in gene therapy. But think of this. This is the capsid of the virus, or the capsule of the virus, that serves as the missile to get our gene in here. And this is what basically the gene looks like. It's a very simple gene, only has 2 genes of its own, and it's when we do gene therapy, we must take out the genes of the virus and replace them with the gene of interest. And that's the gene of interest, and it's a very small one, but it really, so we must remove the ones that are there, put in the ones that we want to, and then load this up into a capsid, and we rely on our vector production facility to do that for us. For Duchenne, and I want to just mention this was the actual first trial we ever did was in alpha-sarcoglycan, but the first completed trial we ever went through was in Duchenne. And the problem with Duchenne dystrophy, and one of the reasons we have more optimism about the sarcoglycans, is the gene is very big in Duchenne. It's one of the largest genes in the human body, and in order to make it fit into the capsid, this missile that's going to take it to the nucleus of the, we must really pare it down. So we take all these other elements out and make a very small gene out of this very big one, and we have to hope that this will work as well as the God-given gene. We don't know that for sure, but we call it a mini dystrophin, and this is basically what it looks like. This is the simulation of what I showed you before in a slightly simpler fashion, where the gene is in the virus and takes its place. This is the first gene therapy we did for muscular dystrophy, and this really represents pretty much how we do this. We have a radiologist who sits next to me, and when I inject the gene, he guides us with an ultrasound so we know exactly where the needle is going, and that makes it possible for us to actually identify the same area when we go to biopsy that area, so that we get the maximum information from that gene transfer. The problem that we discovered in one of our trials, and in talking to some of the parents today, I mentioned that every trial that we do, we learn something from. This was a totally unexpected lesson that we learned from doing gene therapy in muscular dystrophy, and that is that we had pre-existing immunity to actually the dystrophin that we put in. This was a complete shock, and in the field it had been said this would never happen. Don't worry about it. You're putting in this foreign gene, but you have these things called revertant fibers that actually we described back in the mid-70s. And revertant fibers are these small clusters of muscle fibers that express dystrophin, and they are in a sea of negative fibers here, but we have this cluster here. And why do we have this cluster here? Well, we have it because we have a very large gene, and we skip over the mutation. This is the area of the mutation which won't let the gene work. But the body itself can skip over it and make these small clusters of virus. And this actually is the whole principle for exon skipping, another trial that we've just completed and been successful at. But that's in muscular dystrophy. And I bring this up only to show you that what we found in muscular dystrophy in this big red bar is significant enough. It says that when we put the gene in, this big red bar appeared telling us that we had an immune response, and we were very, very surprised to see that, and it prevented any gene expression. Now, the reason I bring it up is because that's not a problem in limb-girdle muscular dystrophy. We see no immune response to alpha, and we don't expect to see any immune response to beta sarcoglycan. So that is to the sarcoglycan that we put in. Getting an immune response to the virus is somewhat different, and I'll show you how that works. But this is a picture of where we are in the limb-girdle dystrophies. I assume that most of you here in the audience are familiar with the limb-girdle dystrophies, so we don't need to dwell on this, but we have 21 different forms of limb-girdle dystrophy, and they're inherited in different varieties, giving them these symbols called 1 or 2. Most of the ones you're familiar with are 2, and here's alpha that we did and beta that we did, and our good colleague here who talked later this morning about the gamma sarcoglycan gene therapy. So the delta, this is delta and this is gamma, I'm sorry. But these are the sarcoglycans and where they fit in with the rest of the LGMDs. So the talk I just want to show you the effect we had on alpha sarcoglycan to tell you why we're very optimistic about beta sarcoglycan. This is a picture here of where the sarcoglycans are. They sit right next to what we call the dystrophin glycoprotein complex. Here's dystrophin that causes Duchenne dystrophy, and it's absent in Duchenne, and then we have any one of the sarcoglycans that are absent. And look where it's localized in the membrane of the muscle fiber. When it's absent here, it makes the membrane very fragile and causes the membrane to disrupt and causes these holes in the membrane. And these membrane defects then get larger over time and then get multiple membrane defects within the muscle, and ultimately these muscle fibers are lost when we have very weak patients and are replaced by fibrous connective tissue. And that is a big problem because we also have to think about when in the course of the diseases we treat these conditions, and the earlier we treat them, when there's less loss of muscle fibers and less fibrosis or less scar tissue in the muscle, the better off we'll be. Now, this probably I need to tell you little about. The sarcoglycanopathies as a group tend to be a variance of Duchenne in many forms. We have Duchenne-like patients who are affected very early, some mild and later onset, more like Becker patients. Generally, children have onset between 3 and 15 and then manifest as ways you know with difficulty jumping, running, and easy to differentiate from their peers. They have very high blood levels of CK, and they become wheelchair dependent most often by age 15. But some are milder, as I mentioned, and then and they are in better condition. Now, most of the problem here is that later in the disease, the patients develop scoliosis or curvature of the spine and respiratory insufficiency, and then start dying early. But one of the things about the sarcoglycans that is of interest to us and interest in the funding agencies is that it tends to spare heart muscle and definitely spares cognitive function, brain function. So that if we can replace the muscle, the skeletal muscle, and this is our target, then we have a much better chance of helping the disease. Now, the first trial that we did in limb-girdle dystrophy was in the alpha-sarcoglycan. This is what we call a double-blind placebo-controlled trial. It was intramuscular, and we didn't want to, or we didn't have an intention in this particular trial to help the patients, but just to prove that it could be done. And this is what the sarcoglycan gene that we put in looked like. It had, here's where the genes for the virus were that we took out and replaced the gene for sarcoglycan. And when we did this, we put this in very much like I showed you with, I was injecting here the foot muscle of the patient, and we had it ultrasound guided. By ultrasound guided, we could actually see the needle pass into the muscle as you see here, and this is what the muscle looked like that we injected. We put the gene in this way, and we had a very high concentration of the gene in here, and this is extremely important to the FDA that we were successful in this trial and we had gene expression that was very easy to detect over over a 6-month period, except with the exception of one patient. Again, a lesson learned. The lesson learned being that despite the fact that we had no immunity now to the sarcoglycan gene, what we did have was immunity to the virus. And in this one patient that we didn't expect, we had a viral reaction that we saw within the first week of doing gene therapy, and we knew that. And this patient, this is expression of the virus, and this is the lack of expression. So we never got any expression. So when we put the missile in, the immune system reacted immediately and prevented the delivery of the virus to the right place in the nucleus. And we also found that within the first week of therapy, we had extremely high antibody titers. And this was exceptional to the rest of the patients who had never got up to this high. This was over 100,000 dilutions, and so we knew that this patient never developed any gene expression. So what we learned from this first IM trial was that we could get sustained gene expression for 6 months. The FDA liked this very much, and we didn't have any adverse events. And I was asked this morning about something I hadn't thought a lot about in terms of just conveying the idea. But even though we had this immune response, the patient felt absolutely nothing. There were no signs of it externally in any way. It was only a blood reaction. And we could detect that in the blood. And this is something that we do now before we ever start. We check each patient to make sure that they don't have an immune response either to virus or to the gene or the sarcoglycan that we're putting in. The other thing that's important about this trial was it was a departure from our previous 2 attempts at gene therapy in this alpha-sarcoglycan, because we use what we call is a muscle-specific promoter. When we put your body, for every gene you have in your body, you have to have something that tells the gene when to turn on, and that's what's called the promoter. And we put our own promoter into the gene, and this is a muscle-specific promoter that protects the patient from having the gene expressed in the wrong place anywhere in the body. So this was a very notable trial in that it was the first time a muscle-specific promoter had been used. So now we're working on taking this to vascular delivery, and that's where we'll go with beta-sarcoglycan, as Louise will talk about, but I'll just mention a couple things. We recently presented this at one of the regulatory agencies at the FDA, and they were very receptive to the idea. And basically, we're going in the LGMD 2D trial, which we're just about ready to launch. We will do 6 patients. We'll use what we call our RH74 AAV. It's really a variant of AAV 8 and 10. It works very well in crossing the vascular barrier. We use it with a muscle-specific promoter. And then when we do this, we've done this many times in monkeys now, and we've had very good success throughout the whole extremity. And what you see here is that when we inject this gene into the circulation of the lower extremity, these bars represent every muscle in the leg, and every muscle in the leg now expresses it. This is different than injecting one muscle. Now we know if we inject this into the circulation of the extremity, that we can get gene expression in every muscle of the leg, so that we should be able to reverse weakness in the lower extremity. And so we're very optimistic about that. And basically, to give you a summary slide of how we do that, this is something we've now practiced over and over again in the non-human primate, or the monkey. We do what we call recirculation, and we take and put the catheter into the femoral artery of the leg with a tourniquet on up here, and then we take the femoral vein, which is the vein that takes things back to the heart, but we intercept it and bring it back to a bag that we hold the blood in, and then we put the gene in and then recirculate this for 30 minutes, and we get very good gene expression throughout the leg, just as I showed you. So that's in the monkey. We know we can do it. Can we do it in humans? I think so. We have no reason to think that we can't. When we took it to the experts in the regulatory field, they were very optimistic, and we call this clinical isolated limb perfusion. The clinical protocol that we'll use, just to summarize this quickly, is that we use what we call a dose escalation study. Every gene therapy study has a dose escalation. That is, this is usually mandated by the FDA, where we start out with a low dose and then a high dose, and we can even add a higher dose on in another 3 patients. In this particular trial, in the LGMD2D trial, we'll use the distance walked on the 6-meter walk test as the outcome measure, as the main outcome measure, along with gene expression. And then our efficacy will be how much increased distance there is. This is the same thing we've used for the exon skipping trial in the Duchenne that we've been successful at. So I think we're looking good for the LGMDs. That's our experience up to this point with Duchenne, where we had barriers to gene expression because of the transgene. And actually, to give you some follow-up on that, we've just done a very large study in our Duchenne population in 70 patients to see how many patients with Duchenne dystrophy would have reaction to the transgene. And we have some optimistic results in the sense that if patients are on steroids, we have about a 20% chance that they'll have a reaction to the dystrophin. If they're if they're not on steroids, that will go up to about a 50% chance that they'll have a reaction to transgene. So obviously, what do? We put those patients on steroids before we do a gene therapy trial. And we're currently doing that in a Becker dystrophy trial. And so things are looking very good, and we're very optimistic, and I'll be glad to open this up to questions. I think I'm within my time limit, at least I tried to be. Louise and I have to catch a plane back today and have it.
Thank you very much, Dr. Mendell, for your very clear presentation, very exciting presentation. Grazie per la sua chiara presentazione.
Thank you very much for your presentation. Of course, the presentation is open also for questions. If you have any questions, please do not hesitate. Yes, please.
On your chart about the perseverance, the lasting effect, you said that you had discovered gene expression up to 6 months after the test. But how much longer does it last? Is there a chance that even though the gene is installed as an episome, that it will eventually wash out or be lost, destroyed in some way?
Well, for one thing, it'll never be lost, that's for sure. Could it be turned off and not express anymore? Yes, but that's not been our experience when we do mice or monkeys. We see expression for up to 2 years. But the truth of the matter is, we can never know the answers to these things until we do clinical trials. That's why treating and being successful in mice is of value, but it is not the answer. We have to do clinical trials. And frankly, the reason we can do clinical trials is because we have parents like you and other parents, obviously here today, who are interested in pursuing this. And without the cooperation of parents, we would not be anywhere in terms of doing clinical trials. So we're very grateful for that.
Thanks.
Altre domande?
Other questions?
In sarcoglycans, in the sarcoglycan, we only had 1 out of 6 patients who was allergic to the virus. But so it's not very a sample is not big enough to give you a statistical evaluation. But in Duchenne dystrophy, the best answer I can give you is that we have for the virus itself, I mentioned that we had about we have overall very few patients who are allergic or have an immune response to this Rh74. And the reason is that, and this is something that I didn't realize until I talked to some of the parents this morning, that the human virus, AAV, there are over 100 different forms of AAV. There are only 2 or 3 that are common in humans. AAV2 is the most, AAV1 is next, and then AAV3. Beyond that, there is not a lot of immunity to the virus. So we don't expect it for AAV8, but it is possible, and people have begun to study that. There have been estimates that up to 15% may have pre-immunity to AAV8, but we just don't know right now. And and we also know that if we do have an immune response, we can give a medication like steroids right away and suppress the immune response. Once the virus gets in and delivers its goods, so to speak, to the nucleus, we're safe, at least up to a point. And then if the body starts reacting to the virus, we can suppress the viral reaction and the gene will be left in place.
Qualche altra domanda? Qualche altro...
Is there any other question? Any other thing that must be clarified? Please, microphone.
Of your patients the same in all patients, or are different alpha-sarcoglycan mutation?
They were different. The most common is the RC77C, and that's the most common of the mutations, and that is more overrepresented in the group, but it's not the only mutation we had. Yes.
Prego.
Is it known, or do you have an idea why reactivating dystrophin induces an immune response while sarcoglycans do not?
Yes, we have a very good idea about that. And the reason is that in Duchenne dystrophy, your body has this large area of mutation, and the body has trouble expressing the gene. So it's more likely that you'll have a reaction, and then we found that these revertant fibers, these small clusters that the body produces sporadically, can have what we call misfolded proteins, and those misfolded proteins then can be immunogenic. The sarcoglycans have a huge advantage because almost all of them have what we call missense mutations, and the missense mutations will continue to express so that none of the patients are completely deficient in the sarcoglycans. They'll have some, and throughout the body, and that will protect them. So the body is used to seeing the sarcoglycans very early. So when we put the new one in, it can differ only by 1 or 2 amino acids, and that's okay.
Qualche altra domanda?
Is there any other question? Okay, we would like to thank Mr. Mendell.
Okay, thank you very much.
You're welcome.
Grazie ancora.